all can be done, where we sensitize and differentiation of the granulosa cell starts happening, increased response of the FSH increases, so the number of LH receptors increase, and then the downregulation of FSH LH receptors happens. Quite a times, there are almost 40% of the patients start ovulating with this hormonal therapies also. So even prednisolone can be considered, where you start with 25 milligrams, 4 weeks. Plasmapheresis can be done, and then pentoxifylline, apoptic inhibitors. All these things can be one of the ways how you can help these patients. So initiate a therapy on time. Specific approach needs to be done. Call them for evaluation on regular basis, so that their quality of life can be improved, because patients very young, we see in our patients where they have POF, and they can be in a lot of trouble, like I mentioned, from cardiac problems to bone marrow density, and which is reducing their quality of life. So quite a times, hormone therapy, whenever we are talking, they come with their own advantages and disadvantages. We can't put them on hormones forever, and they have to keep popping in the pill every time, and a lot of people may not be interested in that. So then it comes of, what do we have, what are the options that we have? And we know, of course, the estrogen, progesterone, whatever we do, it may not, because we have understood the physiology now. So there's a different problem sitting there, and just a substitution with the estrogen and the progesterone may not regenerate the ovaries. But then, since the mechanism is something else, we need to get our attention to something else, and that is where our attention falls into regenerative medicine. So regenerative medicine, when I'm talking, we're talking about repairing, replacing, and regenerating the ovaries, or any cells for that matter, which is there. And we are making the functionality of the region that it is being used. And these therapies can be, got from either the embryonic cells, the adult cells, and they work in the mechanism where we are increasing these growth factors, where biomaterials are used, tissue engineering processes used, cell therapies are used, where we are trying to increase the epidural growth factors, fibroblast growth factors, platelet derived growth factors, vascular endothelial growth factors. So we're using a lot of these growth factors, which will help in repair of the cells, replace the cells, regenerate, and increase the vascularization of these cells. They bring the platelets, starts getting aggravated, and that is how the growth cells also starts increasing. And the it's an anti-inflammatory effect. So tissue inflammation starts reducing, and this is how it can start working. So there have been uses and histories of plasma rich growth factors being used in the past, and we all know PRPs have already been used by cosmetologists, for wound healing, ophthalmologist, neurosurgeon, orthopedicians in a greater extent, where they have extracted platelets from the blood, and they've used it in several regions. Now, when I started long back, I think almost 6, 7 years back, we started with platelet-rich plasma. Like how your curiosity starts, like in a fertility unit, we start seeing a lot of patients with premature ovarian failures. Patients as young as 30 years start coming with low MH, and then those days all you had to offer is oocyte donor, and people will not be agreeing so easily to go for a oocyte donor. So started looking for journals, and started with the journey with the platelet rich plasma. And we did see quite a few effects in this ovarian insufficiency patients, though we know if it is affected with either the chromosome, genetic, or autoimmune causes, you cannot help much. But some variable, initially when the FSH is not very high, we would definitely see quite a few um, you know, results in these patients. Quite a few conceived as well. Whenever we using the Doppler, we saw that the vascularizations were better, the hormone measurements in terms of AMH getting better, FSH falling down, E2 started getting better, and even at the end of 40 days, 45 days, things looked quite good. And then we would start the ovarian stimulation, and responses were really good, and the positive results stayed almost for 6 months. And of course, great qualities were much better, but not to a greater extent. And that is when we started exploring of what could be better than the PRP. So ended up coming across stem cells, where realized of just the basic stem cell is the ability to have a treat a wider range of disease, where it works, and we know it has already been used in leukemias, aplastic anemia, sickle cell, thalassemias, and arthritis, multiple sclerosis, spinal cord injuries. And why should we be left behind in gynecology or fertility? So what is the stem cells? Basically, we all know that stem cells are undifferentiated cells. So whenever they are put into a good environment, in the right environment, if they are put in, they have a capability of differentiating into any form of cells that they are in that kind of an environment. And stem cell have the capability of becoming 20 different kind of cells in a human being, provided the right environment. So that means once you put in, they have the capacity to proliferate, and they have a capacity to regenerate and produce progeny without going any differentiation. So they can self replicate, self renew, only in an appropriate condition. So these stem cells can be got from the hematopoietic stem cell of the umbilical cord, bone marrow, peripheral blood. They can also be taken from the mesenchymal cells from the umbilical cord, again adipose tissue, dental pulp. And hence with this lot of trying on lot of patients, we are overdue due to publish, where we have done a study of 100 patients. We've also had a lot of studies on thin endometrium. And I've been trained under Dr. Prabhu Mishra for the stem cell. We also conduct a lot of training programs for stem cell. So let's look into how this stem cells have been working. We already understood the physiology. So if a POI case is there, we know that the ovarian follicle number is lesser. But when we have tried a stem cell, we are saying that the primordial and the secondary follicles are coming up. The atresia of the follicles are lesser. Folliculogenesis is better. In a POI patient, we see that the FSH is very high, AMH is very low, E2 is low. After the treatment, we saw that the FSH dropped down, AMH got better, antioxidants got better, mitochondrial transplantations were better, pro-inflammatory cytokines reduced, regulations of T1, T2 cells started increasing, anti-apoptic factors increased, angiogenesis microenvironment was all better. So, it is very good, I would say, in patients for ovarian stimulation, for patients, especially POI and POR patients. And, it's been used in a lot of patients, and also as a social treatment for perimenopausal women as well, because of their problems of the perimenopausal symptoms that they are going through. And I'm just presenting our study here, where we had we wanted to see patients where their FSH was very high, AMH was low, antral follicles were low, and very low patients, we didn't take them for study. And we saw in our outcome, we were comparing the number of oocytes retrieved, the embryos formed, clinical pregnancy rates, and the ovarian markers were assessed. And we realized that it was a game changer, where we could offer into a lot of patients. Let me see if the videos play. If it doesn't play, I will play the videos if you people are still interested to see the videos. Yeah, sorry, I think the videos are not playing. I can play it separately for you guys after the while we are asking questions. And we do the ovarian regeneration through the stem cell injections into the ovaries through either laparoscopy. We have tried it through ultrasound as well. But as an infertility specialist, most of the scans of our patients will be done by ourselves. So we assess, what is the ovarian size. Only if it is feasible, better to do it through ultrasound. If it is very streak ovaries, doesn't make any sense of doing it through ultrasound, because it's going to be difficult, especially like this ovary you can see. Imagine if you are going to do this approach through a ultrasound, where would you be injecting? How could you even hold? It's not going to be possible at all. So coming to our results, we saw that we had seen an improvement in AMH from values up to zero point 0.8 to 1 in 17% of the patients, between 0.5 and zero point 0.8 into 50%, and almost 5% we didn't see any raise in the value at all. Antral follicle counts definitely increased in 83% of the patients. We had almost 3 patients who resumed their cycle. Initially, they were getting only on withdrawal bleed. Now patients didn't need medications for withdrawal at all. They started getting spontaneous cycles. Of course, these 3 patients have not yet conceived. And our success rate was around 13% for POI patients. 13% may sound a little lesser, but then we need to remember these are the patients who had no choice but to go for a oocyte donor to have better results. And we are happy at least they could have their own progeny. And these are some of the reports in comparison, where these are of the same patients, the same doctor, that's me, and the same patient who had come next time for post stem cell for a treatment, where in the first cycle we had got just 5 oocytes, M2 were 3, fertilized were 3 embryos. Later we got 10 oocytes, M2s were 8 and fertilized 8. And another patient where from 5 oocytes to we got 7, but the M2s were much better, the fertilization rates were better, and you can see a increase in the AMH value from 1 to 2.3, 0.9 to almost 2. And pregnancy rates were also good, where the p value, this is the due for publication studies, I'm putting the charts here because it's a closed group and all the doctors group. So here the p value was quite significant for us. The embryo quality was much better. The chart shows all favor, and the oocyte numbers got better for us. The antral follicle got better. The AMH were better, where the p value was less than 0.001. The FSH had dropped down drastically for these patients, but the only problem I feel is there is no standardization of how are you going to prepare um, your stem cell, because each one of us are trained in different places and each one of us have their own protocols. There are definitely larger number of studies needs to be done. I would say it is an evolving field, but definitely not experimental, because there have been quite a lot of publications, quite a lot of babies being born where there have been no pathologies. And of course stringent following of the treatment protocols is very, very important. So multicentric randomized studies need to come out, and having some standardized techniques is something very important. Consent with your patients is very important, where we tell that it may not be reflected on the AMH values, but I would always say to my patients that it's an adjuvant treatment modality. It's not an sure shot treatment modality like an IVF or an IUI, but then I always tell it's an adjuvant treatment protocol uh, before we do our IVF and then go ahead. Like I mentioned, I think I'll play the videos post that while we are discussing. And I would end my talk here so that I can take more questions. In the meantime, I'll try pulling out some of the videos for me. I'm open to questions.
It was fantastic results that you have shown, and thank you for sharing them with us. Few questions, Shruti, will you ask
Yes,
Madam
sir.
the questions?
Yes.
Yeah.
Ma'am, the first question is, what does PRP of stem cells improve? More primary or secondary oocyte or oogonia, and how soon?
This is why I said on that primordial follicles, we saw that everything, the atresia is happening post that. So here you're triggering the primordial follicles to come into the active phase. So we are trying to, because there is more of fibrosis there is no vascularization there. So they're all resting in that phase. So this is where you're triggering them to come into an active phase of being gonad. That's why I said, the chart is all very important. And I know, amongst we have wonderful doctors, but, sometimes we forget. So this is why I always like putting that physiology chart. Sometimes it gets boring, but then, we are trying to trigger them up and bring them into the later primordial and the secondary follicle stage.
Okay.
It
Have you
would take
used stent?
definitely
Yeah,
six
yeah.
weeks at least to see the results. 6 to 8 weeks.
Okay. Uh,
And ma'am,
yeah,
can,
yeah, 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 Shruti.
and someone has asked, can you stimulate the very next cycle after the session?
No, no, only for thin endometrium. See, we have another study again that's also in the peer review already. So there only if it's for thin endometrium we use it in the immediate next cycle post the stem cell injections. We don't install, we do injections under the endometrium. But then for ovaries, definitely I would give 6 to 8 weeks gap.
Okay. My question is, have you used stem cells as well as PRP both in the same ovaries?
If you want me to
Would
be
it?
very frank, I would say yes, sir, because
Yeah.
what happens once we are installing, be it in our ovarian stimuli pickup needles, you have a long shaft there. So we are hardly getting 2 or 3 ml of your stem cell and you're pushing. So I don't want to be using a saline to push that. So I always take that PRP, this thing, and so that we have definitely both the effects.
Yeah. So, but then it is very difficult to differentiate whether it is because of PRP or because
Yes.
of stem cell.
Definitely, sir. Definitely. But then why? Because I started my career with PRP. So it's just that I realized with stem cell, we have a longer duration of the effect staying there.
Yes.
Concept is basically the concept is the same where the growth factors are acting. Be it
True.
our peripheral blood or the stem cell, it is just that the stem cell, you are getting your hematopoietic cell from the origin. So the effect remains a little longer. And
Yes.
it's definitely a better quality from what you're getting on the peripheral blood.
Okay. Any incidences of abortion or chromosomal anomaly in the
Yes. Yeah.
yes.
I've had it. I've had it because with so many studies, so many patients. I've had 3 patients, and we've just written 3 abortions. We've not written down on the journal of why. But then, yes, I was thinking the same because you have forced those aged oocytes to come into the pool, and that is how it has happened. And that too, they were all day 3 transfers. So
So
we lost one at 6 weeks, one at 8, 2 at 8 weeks. So
so
it was a
would you
mistake.
advocate PGT in all these cases?
Yes, because it was day 3 embryos, we couldn't, and the patient didn't want to wait for day 5 because whenever we are freezing at day 3, we tell the patients, if we go at day 5, we may not get embryos at all. So it
Mhm.
was with the consent of the patient that we had to freeze it day 3.
Okay. Okay.
So
Ma'am,
do I
next.
have time for videos?
Yeah, yeah, we have
I
time.
can
We have
take
ample
questions
time.
whenever maybe we are done. I can play the videos.
Yeah, actually, you can start screening because it will take some time.
Yeah,
How do
yeah,
you
sure, sure.
prepare stem cells? Is there any specific license
I
which is
can show
required
that.
for
I can
stem
show
cell?
that in the video, sir.
Yeah, yeah, please, please, please. So the preparation of the stem cells is in the videos, right?
Yes.
Yes.
So I'll put the volume down so I can speak and then we can talk
Yeah.
about it. Okay. So I call an orthopedician. I always like I hope the screen is seen.
Yes, yes. It
Yeah.
is seen. It is seen.
So I like sticking to what I'm good at. So I don't, I know a lot of gynecologists try doing this, but then I leave it to my orthopedician. So this is a Jamshedi needle which is going into. I have 2 orthopedicians. Some of them like using the anterior iliac fossa. Some of them like doing the posterior. So I feel posterior is much better. You get better volume from the Jamshedi needle. Around 13 gauge of Jamshedi needle is used, and please remember every 20 ml you get, you're only going to get 1 ml of your growth factors. So at least minimum 40 ml is definitely something which would be better. So after you have drawn from the marrow, you go into, this is again from the drawing of the marrow, where you these syringes are all heparin washed, and then only you try to aspirate from the bone marrow. You can do it either from the anterior or the posterior, and then you go ahead. And these are taken in the falcon tube, where again the first one falcon tubes are all heparinized, and then you do a wash for 12 minutes at 1018 100 rpm. So once that is done, we are going to get a filtrate like this. So please take only this top plasma. So you take only the top one. This would have become with your 1800 RPM, it would have become harder. You won't be able to do it. So you again draw with around 18 gauge needle. You try to extract only this plasma. Then you recentrifuge for 6 minutes at 3,400 RPM, and then you do it. Now you get a lot of these companies. So initially when we started, even now I do it quite a lot of my patients. Sometimes I get calls from other hospitals to come in. So you could also be using this, which is a very good separator, where you don't have to do it manually by yourself. It is just that it costs on the patients. So you can use all these things, and then it should be less blood contaminated. So if you're doing it transvaginally, uh, it is just like our egg pickup. It's the same guide, which is the same transvaginal probe, and even the needle is the same. So you try to do it under scan. Like I mentioned, please make sure you choose patients very well. Only if your ovarian volume is good, please do transvaginal patients, because infertility patients, we see most of them would have already finished diagnostic laparoscopy. They come to you, a lot of things are already done, so you wouldn't get a choice. So try and choose patients where your ovarian volume is good, otherwise you're going to have a lot of trouble. So you are going to inject it exactly like how you're going to do an egg pickup needle. It's the same egg pickup needle that we are using. So like how you enter for an egg pickup is similar way. You go just around 2 millimeter, one millimeter or 2 millimeter depth, and then you inject. So like sir mentioned, if you get, once you've done this, please remember the buffy coat is the one which is rich above the blood which is clotted. Just around 1 ml of that is the platelet rich plasma, and after that is all platelet poor plasma. So again, you can use that for flushing as well. So you can see the needle here where you're injecting, and it goes right under the uh, underneath the cortex. So this is in the laparoscopy patients. Like I said, you can see you have to be very diligent. Sometimes in this thin ovary, what happens if you go very perpendicular, you're only going to come out. So it is very important you stay parallel to the cortex, and then very nichely it has to be done. So we get a lot of observers, we get a lot of fellows, trainees. So you have to be very slow. Only then it goes inside. And yeah, this is another ovary. This is one of the workshops we had done. Our AMH is quite low, and you can see that you need to go underneath. You need to underneath the cortex, go inside, and slowly you need to inject. So again, if you're going to do it very forcefully, it is only going to come out, and you have to be very careful, because if you overshoot, you are again going to puncture, and if you puncture, there is no point, because it is one side you push and it is going to come out from the other side. You can see the welling up of the ovaries. Stay there in that place, and and then only come out.
Mhm.
So
Madam, what is the volume you've injected in each ovary?
So you place it. So this is how you're going to inject. So stay there. You can see nicely welling up of the ovaries. So if you push too much, it is going to come out.
So Dr.
Stay
Lavanya,
there for some time, and yeah, slowly you need to come out.
so what is the volume that you inject? Roughly 2
So,
ml?
sir, we'll be able to do only around 1 ml, nothing more than 1 ml will go. See, even here, if you try seeing, I do it, I'm yet to publish. I'm trying for my endometriosis patients. I've seen that the recurrence are much lesser. So this was one of the patients like that. So only 1 ml is maximum we can try. If you try pushing out, most of the times it comes out.
I see that you are using this Sanket's needle, I think, the one which we use for vasopressin injection.
Yes, yes,
Yeah.
yes. So that's
So,
why I said, sometimes we go, and for the workshops we do,
yeah,
depends on what is available.
yeah.
And this was another place where we tried using the spinal needle.
Huh.
So sometimes, like I said, a lot of patients would have already gone through a lot of procedures. So we just wanted to cut down and try this. So we use the spinal needle where the ovaries were brought near the abdomen, and then so we are reducing one port, and you can see that this is our spinal needle. We have tried with our oocyte pickup needles as well. Works wonderfully well. And sometimes we are also debating, so many times it is like the trauma that you are causing, that could also be increasing your uh, growth factors as well. These are some videos which I have for the thin endometrium.
Mm-hmm.
The process is the same, but there are a lot of people who install, but I like injecting underneath the endometrium. You saw how, and you can see beautiful welling up of the endometrial lining there. So just go parallel to your endometrial lining. These are patients thin endometrium, were very difficult. You can see the welling up so beautiful. So you inject it on all the walls, and you go by. So this is all hysteroscopy guided, and here we using, you can see the welling up here. So yes, thank you for allowing me to share my videos.
Yeah. Those are fantastic videos. Yeah. Now, few more questions for you. One is you said that you request the orthopedic surgeon, but then why not the those hematologists? Why not
Oh
hematologists?
yes, yes. I'm right now also I'm in a multi-speciality hospital. Previously also I've been in an onco center where we used to run our fertility lab. So always we've had the hematologists, and I've had better results when my hematologists are coming in. So yeah, sometimes they are busy. So most of the times, like I said, I'm freelancing for fertility sometimes. So I have orthopedicians. So hematologists don't have time to come along and freelance. Orthopedicians are more accessible that way.
Okay, okay. Now, very valid question from Dr. Krishna Kumar. Can any center extract and do stem cell, or do you need a ICMR permission?
This is again, we've been debating over this because what only the I have that. Let me try pulling out that as well. So again, if we are separating and putting it on another sitting, or we are trying to separate out the cells, you need a permission. Otherwise, if it is in the same sitting and you're only centrifuging here, we are not trying to separate out the cells, so we do not need a stem cell approval or the licensing for the same. So the licensing is required only, this is from the government of India. So only if you are centrifuging, minimal manipulation is allowed and the same sitting is allowed.
Hmm.
Ma'am, how many sessions are required before you see a difference?
To be very frank, we have not repeated for any of the patients.
Single
Okay,
use.
I think it would be sensible to tell them to go for other options if it is not working. And we do get patients request saying that can we try another one time. I have not encouraged anybody. I would prefer just do one this thing and it works, fair enough. Yes, of course, thin endometrium, good. You can do it because less invasive compared to an ovarian regeneration. But ovarian, no, we have not repeated for anybody.
There's another question. Can it be used in, can stem cells be used in oats and azoospermia?
Uh, Theoretically, yes, but I've discussed with quite a few andrologists. Some, I have one or two andrologists who claim very good results, but quite a few of them not very happy results. But yes, it is theoretically, yes, could be used.
Hmm.
The results are not very satisfactory for whatever I know of.
There's another question. Which needle do you prefer to inject? I think Patil's needle is there. I think you are using the same part.
Yes,
It is,
yes, yes,
yeah.
yes.
I think it is available with KK Surgicals. It is for 3,500.
Correct.
Yeah.
Yeah. So you can, I mean, if it's easy for you, if you're in a fertility unit, you can use your egg pickup needles also, your cyst aspiration needles, even our laparoscopic needles. Like again, there's a theory, na, like that itself is causing some activation and all these things. So anything that helps is finally, I think, results is what we need.
Okay. Yeah. Uh, Under anesthesia, so this is for the endometrial rejuvenation, I think. Do we inject PRP under anesthesia or stem cell under anesthesia?
Yes, see, we are not installing. That's why I said I do have quite a few of my friends who practice installation, and there the theory, I've spoken to them personally. So they say the theory is like how we are doing an IUI, you're installing, and how is the sperms moving? It's all because of the contractility of the muscles. So when you are installing, you don't need anesthesia. So you do it like your IUI, and it should be absorbed. But for me, I would say you're spending so much, you're taking the blood, you're trying to prepare, why just install and leave it? So there the physiology, if you start thinking, the inflammation or your reaction is going to stay for 2 or 3 days. It's a momentary thing, but you're not trying to correct. So I would say inject it, so that your endometrial basal endometrium you're injecting, so your action remains for a longer time. And if you're talking about injecting, then you're talking about operative hysteroscopes, and then your diameters are more better. So always go for anesthesia. It is more peaceful for the patient, for yourself as well.
Yeah. What is the medico-legal status of stem cell treatment? I think you've already.
Medical legal case, I think medical legally, I think we all have to be safe like any other procedure. So this is where our consents, our dialogues with the patients, not over assuring them, and not saying that, it is a treatment modality. That's why I said, you always have to be safer and tell them it's an adjuvant treatment only. It is not a sure shot of treatment, and no over promising to the patient. So be very frank with the patients, and I think that is when we have a better, or lesser legal problems.
So probably before we take up any fertility enhancing surgery, there are a lot of things at the back of our mind that we should be aware of. One is of course the AMH level, because then again, if it is low and then you are doing a simple diagnostic laparoscope, at the same sitting you have to do fertility enhancing, you have to do PRP, you have to do stem cell and everything. So that only in one sitting the patient should have a complete gamut of therapies which is there. Chance of infection at the bone marrow site.
To be very frank, over nearly 150 cases, I've had two patients who came with severe pain in the stem cell where we had picked up. Only two patients reported. One persisted for more than 14 days. That was a little scary for me. She was a patient, NRI, who had to travel back, so I had to cancel her for, flight travels. Another local lady who had come and persisted for a week. I couldn't get any cause. We did everything that was required, put her on antibiotics, everything, but then cause was not known. These were the two patients. And the other thing that I have seen is, sometimes I'm seeing that this is cyst formation, especially when we're doing a laparoscope. Quite a few patients I'm seeing, when they come back, immediately I can see a cyst. I explain, telling the patient, look, your ovary is reacting at least, so that makes us feel a little better though. But then these are the few things that I have noted, but nothing majorly for me to be telling a patient.
Okay. Uh, is there any role of cord blood as an alternative to bone marrow stem cells? No.
Cord blood, what happens, your proportion of what you're going to get as the growth factor is not going to be very accurate. So there are a lot of studies. So what volume you get and what are you going to get as a concentration is going to be very less. So this is why it is not going to be there. And please remember, whatever we are doing is all autologous. So when you're
Compatibility will
doing
be an
from the,
issue. Yeah.
yes. So your concentration will not be good. And when are you using? If you're taking it from the cord blood, it is not for the immediate purpose. Na? So you're reserving. So cord blood, again, you are storing it, you're using it some other time, doesn't make any sense. That is when all your licensing, all those things come. So the concentration in the cord blood is very, very lesser.
One more question. The centrifuge machine used for stem cell. I think spermfuge or Remy, anything will do.
Anything is good, especially the cold centrifuges are much better, because when that itself, yeah, that's another good question. I'm sorry, I'm not seeing the chat box. I was just concentrating on answering the questions. So what happens, that brings in an activation. So when you use a cold centrifuge, so you're using it at 20 degrees, and then when you bring it back to the room temperature, that itself acts an activation. So you don't need to buy any, what I showed you in the videos, we have not picked up any commercial kits at all. All you need is, like in an IVF center, your falcon tubes are just lying down there. You have your 18 gauge needle. So you're hardly spending anything. You have your centrifuge machines in your hospitals. So hardly any karcha in 1,200 to rupees, you're done. Imagine you're picking up a commercial kits for all these things. Your cost to the patient is going to be very high. So because they sell you telling that you have activating factors, you have calcium gluconate, you have this, you have that, you don't need. This itself, temperature change itself is an activator. So, you're, taking it into the syringe, activating. So all this itself is going to be an activator. So I don't think you need any of your activators there.
What would be the cost of stem cell versus PRP? I think PRP will be much cheaper.
PRP is much cheaper. I work in a corporate hospital, so I would say almost 2 to 3 times more stem cell compared to a PRP. PRP is, see, even you don't even need to pay your orthopedician, your hematologist, nobody. So PRP is way less expensive than the stem cell.
And another thing, to activate the PRP, we can always dip after preparing the PRP into an ice solution and
So that's
or
why I
liquid
said, this is why I
nitrogen
said,
or liquid
correct. No,
nitrogen as well.
exactly why I said you can use a cold
Okay.
centrifuge itself. So this is why I was saying bring it at 20 and use your cold centrifuge. Then you're bringing it back to your room
Room
temperature. This
temp,
is
yeah,
exactly what we were talking. That
yeah,
itself is better. So if in case where this keeping in an ice, this thing works is like now you are doing the processing and then you have to come back, put your ports, and till then you can put it in your fridge store and then reuse it.
yeah,
So that itself will, while you're trying to, you don't have to keep it in the room temperature, put it up there, and then you can use it later.
yeah.
Yeah.
I
Any
see
other
Dr.
question for-
Javli lifting the hand. Was it been? I don't know if that question has been answered.
Any other questions? Anyone? Dr. Zavale, Dr. Kamlakar, yeah. How much can we inject into the endometrium? Again, the same thing.
Yeah, it's 1 ml. So you have to go into the anterior, posterior, both the lateral and the fundal as well. But fundal, be careful so that you don't over, because other walls, what happens? You run parallelly. So even if your needle goes a little deep, you are just right there. But in fundus, you overshoot, you're entering your peritoneum. So just be a little careful. So somewhere around 3-4 ml would do a job for you in the thin endometrium.
Okay, so for a thin endometrium, for information of everyone, they have this Patil's needle. It has got 4 serrations. So up to the 4 serration, you can inject into the anterior, posterior, lateral walls, and only up to 2 serrations you can inject into the fundus.
Fundus.
We've already. Okay. Any other question?
Can same centrifugal machine can be used in stem cell and PRP both?
Yes, yes. The processing is the same.
It's same with cold. If even if
Yes.
it is not cold centrifuge, is it okay?
No, yes, it is the
For
same. Yes, no
sperm
problem.
preparation, just same
That,
centrifugal
yeah,
as
if you have no option, it is fine. But like I mentioned, the cold centrifuge always has a better results in term of your concentration for the growth factors.
Okay. After endometrial rejuvenation, is it compulsory to do IVF or ovulation induction? It was
No,
to,
not
no.
necessarily. Not
Hmm.
necessarily. Your indications for your IVF ovulation induction is not going to change. These are not meant for your change in the indications. They remain the same. Yeah, I can see some question of POF not interested in fertility. We have done it for a lot of perimenopausal women, especially when they come with a lot of these hot flushes, dry skin. They have all had very good results, especially like I mentioned, bone marrow densities become much bad for these people. Yes, they have been quite a few. Incidences where not many patients we have done, but when we talk to the patients, they say their symptoms are much better.
Ma'am, next question is how should we counsel patients with respect to the success rate of the treatment?
So that's why I said, please remember to tell them it is not a, treatment modalities, it's just an adjuvant treatment. And like how you're giving medications or a tablet, this is another modality of invasive treatment. So please also don't forget to mention that the AMH results may not increase, because we have seen in quite a few patients the AMH value didn't change. FSH, yes, we are seeing there's a drop, but AMH is very difficult to see it on the value. So please talk to the patients and also tell the patient they have done a treatment, they're not going to be lost for follow-up. They come back after 6 months, 1 year, your AMH is going to be back because your physiology is not going to be halted here. So as the age increases, AMH will come down more and more. So all these things have to be put in the consent of the patient.
Question is, what anticoagulant do you use for preparation of stem cells? I think Falcon.
Heparin, heparin.
I think, yeah. How long does the effect of stem cell last?
Almost, I've had patients, especially when we see perimenopausal people. I've had one patient, I've done IVF. I delivered her yesterday. The first one I did a stem cell. I'm very protocol based. Unless I finish 4 to 6 cycles of an IUI, I don't jump into IVF unless there's an indication. The first one thoroughly evaluated, went for IVF baby. She came back. I think the first child was 9 months. She came back with the second pregnancy, spontaneously conceived, and I delivered only 3 4 days back. So there are a lot of things, and I've seen patients even at the end of 6 months, 8 months, where they're getting their cycles. I told you all the stories that they don't need withdrawal bleeding anymore. So working quite well, but there are not very, at least I'm not aware of any studies which have done studies of how long it stays, but at least minimum 6 to 8 months for a treatment modality. Yes, certainly.
Yeah. Madam, lot of questions on stem cells. So what my question is there any center where we can go and learn how to do the stem cell preparation? Because
You
see,
can
it
come,
is
all
all
of you can come to Bangalore, sir. Or
lovely. Santosh,
Amox
we have
can
to
do
go
a
to Bangalore.
workshop, and I can come over and we can do a workshop or 1 day session only. This we can, I would
Fantastic.
love to do that.
Thank you so much for that. Okay, coming to Bangalore is a good option. So all of those who are interested can ping Dr. Lavanya and she will tell you how to do the preparation and everything. Yeah. Anyway, because see, it will go on and on because again the next question is how much heparin is to be used. So
So I think heparin is just to wash your falcon tube. That's more than enough. Only for your Jamshedi needle, make at least sure 1 or 2 ml you run it at least 1 or 2 times, and that's better.
5,000 unit heparin.
Yes, you can use because you're using it as an anticoagulant. The action is more important because when you centrifuge, you need to separate out. So if the action is done, I don't think we should be worried at all, and that should be more than enough.
so 1 ml at least for the falcon tube, right?
Yes, 1 ml is most important.
Hmm. Okay. Can it be
I'm
used with
very impressed, sir, that you're asking questions, you're typing the answers, and that
yeah,
shows
I
of
have to.
how multi-talented you are.
No, 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 not a question of being multi-talented. It is Amox prestige which is at stake. So we prepare the notes, and at the end of the session, these notes are posted to all the delegates. So जिसको
It's very
चाहिए वो
nice.
notes ले सकते हैं. And the
It's
same thing we
really
did
nice.
for the infertility workshop also. So again,
Really good. And I'm really impressed with the attendance of 170 people at
yes,
9:30, 9:45. Really great amongst.
thank you so much. Any other question? No, I don't think so. Acha, you have a one VIP guest coming, Dr. Lavanya. You have Kumar coming to you. Dr. Krishna Kumar will be coming to you.
Sure, sir.
Anyway, so a lot
More
of
than
people will
happy
be
to.
joining. So I think
More than
in
happy.
case it is feasible, just take a. I'll ping you my number. So those of
Yes, sir.
us who wish to come to your center to learn, I think you can please just be very frank. What would be the charges? Please charge and then take us. It should not be a freebie for everyone. I mean, I'm saying
No.
this for everyone because
We'll
again,
plan.
because again, you'll have
We,
170 people standing outside your OT to read everything. It should not
no,
be
sir.
that way.
We'll plan a workshop, and we'll
Ji,
plan a workshop if possible. We can do it in your society as well there,
sure,
and anybody who's free can come over and can get in touch with me.
sure. Thank you so much.
Thank
Thank
you. Dr. Parul
Yes.
and all these people have my number, so
you.
Dr. Parul can coordinate as well.
Yes, yes, yes.
Yes, thank you,
Thank you,
Lavanya
Dr.
ma'am.
Parul, for this wonderful invite. I think really enjoyed, such being among
We
the
enjoyed
invite crowd.
listening to
So
you,
much
ma'am.
of
It's like
knowledge and
crazily,
exchanging knowledge.
all sorts of infertility and cosmetic gynac, aesthetic gynac coming into picture. So I think it's really, really very helpful.
Thank you.
And
Thank you,
for
Kiran
your
sir. Thank you so
information,
much.
your information, we have about 175 delegates who have registered for the aesthetic gynecology course. So all of them have paid on their own.
Wow.
There is no pharma support. There was
That's really
a there
nice.
was a there was an insistence that we give this particular course to any third party to do the recordings and everything, but I have flatly refused. I have told them specifically that we will buy the Zoom platform. I will do the Zoom recording. I share the Zoom links every day at around 7:30. So it is like purely academic. There is no sorry, no thank you, no inauguration, no buttering, nothing. So everyone knows that they have to come at 8 o'clock and they have to go at 10 o'clock.
I think the dedication is seen, sir.
Thank you so much, ma'am. Thank you. So I think, thank you, madam, for being here with us. And we really appreciate your presence. Parul, can we have the next speaker? Who is the next speaker? And please
Dr.
do the
Aditi ma'am.
coordination. Yeah. Please do the coordination with Dr. Lavanya, madam.
Yes, sir. Yes, sir. Surely I'll do that. I'll do the needful.
Yes.
Thank you. Thank you all.
Thank you, madam. Thank you.
Sir, Aditi ma'am is the next speaker now.
Yes.
Hello, Aditi ma'am.
Hello. Good evening.
Good evening. So I think that's Dr. Aditi Natkarni for us. She's a specialist in fertility and IVF consultant. She's an endoscopic surgeon and international IVF trainer. She's the director of Natkarni's 21st Century Group of Hospitals at Valsad, Vapi, Kilapadi, and Eva Care Fertility Center, Vapi. She's a practicing infertility and high risk obstetrician since more than 15 years. Foxy recognized training center for USD endoscopy reproductive medicine. She's the course director for that. She received the prestigious ICOG fellowship. She's the past president of VAPI OBGY Society. She has been the treasurer also for VAPI for the past 5 years. And she's conducting a lot of fellowships and training programs. She herself is a diploma in reproductive medicine from Kiel, Germany. She's done her diploma in USD fetal medicine from Dr. S. Suresh, Chennai. She's worked in the fetal medicine department with Dr. Chandar Lula and Dr. Nitin Chaubal. She's done her embryology training from Cleveland University, US, and Sydney IVF Center, Australia. She's also received her diploma in laparoscopy from Germany, from Gießen School of Endoscopy. She has a lot of achievements and accolades to herself. She has been recently awarded the Nari Shakti Samman Award by the Finance Minister of Gujarat. She has also participated in numerous state, national, and international conferences as speaker, panelist, moderator, including AICOG, SOGOG, and other conferences. She's delivered numerous lectures and awareness programs at industries, schools, colleges, and she is a
Thank you.
Sangeet Visharad in
Thank you,
classical
Parul.
music. So her melodious voice is all for all of us.
Thank
And we
you.
would
Thank
be
you,
hearing
Parul.
Dr. Aditi Natkarni for endometrial rejuvenation now.
Yes, sir.
Yeah. Thank you, Dr.
Sir,
Aditi. It's lovely to have you here. At the
thank you,
outset,
sir.
please.
Thank you so much for having me here. And I'm sorry, Dr. Akshay couldn't join today. Of
Uh,
course, he's there, but he's traveling. So then he asked me to take the talk. So I'm so thankful to you, sir, and to AMOGS for having me here today.
No, Dr.
Uh,
Aditi, I have not yet finished. I have not
yes,
yet
sir.
finished.
Sorry.
So why I am saying thank you is because all of us have got very, very fond memories of Purnima Madam.
Yes, sir.
As a matter of fact, when we took the infertility course, there were around at least 300 people. And all those 300 people, I am happy to inform you that at least 100 had taken training with Purnima Madam.
Oh, yes,
Very,
sir.
very, really, very fond memories of Madam. So thank you. And in fact, Kishore sir was also there. He was also for the male infertility session. So
Yes.
thank you so much for being with us. And Amos would really love to be associated with your center also for
Yes,
hands-on training at a
definitely.
later date, whenever time comes. So thank you again for being with us. And I assure you that at the next Amos conference, I will request specially, it was going to be held in Mumbai. So I would make a special request to Dr. Amey to include you as one of the faculty members so that you can give your knowledge. And of course, we can enjoy your melodious voice in the evening time when the cultural program is there.
Yes, sir.
Thank you.
Sure, sir. Sure.
You can please start your talk.
Yes, sir. So, good evening, everyone. And today, I'm going to speak on endometrial rejuvenation. So, I bring warm greetings from Gujarat, from Kilapadi Vapi, and we are. I give my greetings, and I also always remember my guru, that is late Dr. Purnima Nadkarni. And it was a center which was started by her long back, that is 42 years ago. And we also have a training center, as told by Parul. So basically today I'm here to speak on rejuvenation, that is endometrial rejuvenation. So it is basically a therapeutic procedure in which the PRP is injected into the endometrium, that is the lining of uterus, to promote cellular regeneration and improve quality and thickness of the lining. So the objective is basically to enhance the receptivity, facilitate better embryo implantation, particularly in cases of thin or inadequate endometrial lining, which is often in context to IVF. So since we are more into the IVF field, we need this rejuvenation a lot because we get so many cases which require rejuvenation in practical aspects, like failed implantations. We have so many patients coming to us who have done recurrent IVF elsewhere, and they come here with recurrent IVF failures, or there is just implantation failure because of thin endometrium, because of inadequate endometrial vascularity. Could be because of other causes like Asherman syndrome, where the endometrium is just not coming up well. It could be because of some chronic endometritis, some past infection. So suddenly we have many cases coming to us with secondary amenorrhea. So there is no cause for secondary amenorrhea, but yes, of course, we have to find the cause for it. And of course, we definitely come to know that there could be some factor which has triggered secondary amenorrhea in this patient. Then, of course, thin endometrium because of the tuberculosis. That is also one of the
Aditi,
causes.
Aditi, can you put it on slide share mode? Because I think
Yes, sir.
yeah, 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 same, yeah.
Yes, sir. Sorry.
Thank you. Yeah, done.
Yes, sir. Sorry. So, of course, a good ultrasonography is the key to diagnosis, which we usually do in each and every patient. And an pre-IVF hysteroscopy or a diagnostic routine hysteroscopy is definitely done to see her endometrial cavity, to assess her endometrial cavity. And later on, we can definitely do the rejuvenation for her. So, what is receptivity? So, receptivity is basically, so receptivity depends upon the thickness, it depends upon the pattern, it also depends upon the subendometrial and the endometrial blood flow. So one of the most challenging problems which we face in treatment of infertility is to deal with thin endometrium, because there are clear cut, there may or may not be clear cut remedies, nor any consensus maybe, which is regarding the management of thin endometrium. We have lots of options, but still many of them are still under diagnosis and under a lot of this. So how does thin endometrium affect implantation? So there is defective endometrial angiogenesis, which could lead to a thin endometrium and a failed implantation. There could be defective VEGF expression, low uterine blood flow, which is leading to implantation failure, endometrial receptor depletion, thin endometrium, which can cause high O2 tension, which is detrimental for the embryos to implant. So these are a few factors which cause implantation failure in the thin endometrium. Some other causes which are anti-estrogenic effects of clomiphene citrate, which is the most commonly used drug in IVF, and of course letrozole also. Endometrial resistance to the circulating estrogens, decreased blood flow to the endometrium, permanent damage to the basalis layer of the endometrium, and of course overexposure to androgens. So persistently thin endometrium should always be evaluated for genital cox, especially in our country. And of course, vigorous post-abortal curettage, severe endometritis can be caused because of permanent damage to the basal layer of the endometrium, which is definitely difficult to treat. So thickness evaluation, we usually do it by a sonography, a good sonography, which reflects the degree of the endometrial priming by estrogen. So the dose and the duration of exposure is important, and it can be evaluated on transvaginal ultrasound. So usually we measure the thickest part of the endometrium on ultrasound, and that is how we know whether this is a thin endometrium or a thick endometrium. And a secretory endometrium definitely looks like this. So the best endometrium for implantation is assessed on the day of trigger. The optimal endometrial cavity, the endometrial thickness should be around 7 millimeters. ET of less than 7 or more than 14 may be associated with a intermediate or a poor prognosis in the patient. So now coming to the management of thin endometrium, it aims basically to improve the estrogen levels, which will in turn increase the blood supply to the endometrium. So these are a few treatment options which we come across. So basically, as a IVF specialist, because of clomiphene-induced cycles, there could be increased dose of, you can increase the dose of clomiphene, or you may switch to gonadotropins, because if the patient is not responding, if an endometrium is not good, follicles are also not up to the mark, we definitely have to switch to gonadotropins. Estrogen, we have different applications. That is, we have the oral estrogens, we have the vaginal estrogens, we have the topical estrogen creams. There is sildenafil citrate, there is GCSF, there is L-arginine, low-dose aspirin, vitamin E, stem cell therapy, GnRH agonist, PRP installation, HCG therapy, and endometrial scratching. So out of these, I'm going to emphasize on a few things which we usually do surgically because it's about rejuvenation, but these are also important adjuvants which definitely help to rejuvenate our endometrium prior to we giving some therapy like stem cell therapy or a PRP therapy, because suddenly the patient comes to you with a thin endometrium. We cannot just put in a hysteroscope and start doing her adhesiolysis or start doing her PRP. We have to first prepare her. We have to give her a little bit of estrogen, especially in case of a secondary amenorrhea. You may just go and rupture. So that is the risk associated with just directly doing a hysteroscopy, but with a thin endometrium or a poor endometrium or a non-formed endometrium. So that is what these are the different treatment options and adjuvants. So these are a few recent advances which we all know, that is GCSF installation, local PRP, that is platelet-rich plasma, endometrial scratching, and stem cell therapy. So now let me say a few things about everything. That is, granulocyte colony stimulating factor is a important and a good thing which is useful for unresponsive or a thin endometrium. So GCSF can also be used in patients. So this was a study which was done. That is, all patients underwent an embryo transfer after GCSF, and the clinical pregnancy rate was around 19.1%. So GCSF infusion was done in intra-endometrial infusion was done. So the procedure was just like how we do an IUI procedure. So it was injected. So usually there is a pre-filled syringe of 300 micrograms of GCSF, which we usually instill inside. And then we usually do the embryo transfer after 3 to 4 days. So basically, what is GCSF? It's a glycoprotein. It has growth factors and cytokines. So the endometrium, macrophages, and in other immunocytes, the therapeutic usages of GCSF, it stimulates the production of WBCs, treats neutropenia induced by chemo or bone marrow. So it has these growth factors. It increases the hematopoietic stem cells of the donor before collection. So hematopoietic stem cells transplantation, it's also used in that. In CNS, it has been said to induce neurogenesis and anti-apoptosis. So it's also used in neurodegenerative diseases, and of course it's used in enhancing the endometrial receptivity. So recombinant human GCSF, it is synthesized in E. coli expression system. So this commonly known as filgrastim. So since we also have an onco center, my husband is an onco surgeon, so we get GCSF quite easily, and it is usually used for our patients, especially with thin endometrium and unresponsive endometrium. So he was the one, Glacier et al. He was the first one to use in 4 patients with dramatic improvement in this endometrial thickness. It improves the endometrial thickness in patients with thin endometrium, especially when it is due to destruction of subendothelial layer and where other treatments for vasodilatation have failed. So yes, definitely it should be used. It can be used. It has also been proposed as a treatment for implantation failures and recurrent miscarriages, which has involved with some immunological process. So it is also useful in reproductive functions like cyclical changes of GCSF mRNA in follicular fluid during menstrual cycle, and GCSF and its receptor in human luteinized granulosa cells. In follicular fluid, it is a useful biomarker of oocyte competence before fertilization. So GCSF and HMG in poor responders also helped to improve the follicular development. So that is how it was usually useful in combination with the gonadotropins also. So yes, we have also used it in many of our patients, and we have definitely got good results. We have a study also. I'll be showing you in some time. So these were the different studies which were done on GCSF, which showed dramatic improvements in thickness, significantly higher endometrial thickness, which showed good improvement in implantation, ongoing pregnancy rate, and there were better clinical pregnancy rates, which were found to be better. So these were the different. Now coming to HCG, some schools of thought also use HCG for injection inside the endometrium. So it is supposed to for prolongation of endometrial receptivity. It also increases the angiogenesis, the trophoblastic differentiation, and also it helps in modulation of tissue remodeling, which may be necessary for the endometrium. And also it plays a role in the receptivity part, which also is important. So this was a study again. So the HCG was given after day 8 for 7 days, and then the endometrial thickness was assessed. So in 17 infertile patients with refractory endometrium resistant to other treatments, and especially in recipients of fresh donor or frozen embryos, this was used. So 52% revealed 10% and 35% revealed 20% improvement in the endometrial thickness. So that was after the patients were given HCG priming. So that was the result there, and that was used in this study. So these were again done in another study where 750 international units of HCG every 3 days concomitant to E2 compared to no HCG group. It revealed significant rise in the endometrial thickness. But of course, study was prematurely discontinued due to some ethical reasons. But yes, definitely HCG is used in some places. Now, let me come to the most useful topic and the most sought after topic, that is autologous platelet rich plasma. So Dr. Lavanya has very beautifully told about platelet rich plasma used in endometrium also and in the ovaries also, and it has also been used in other fields. So basically it helps in cell growth, it helps in new generation repair of blood vessels, collagen production, and of course, the platelets, what we use, they are for FGF, EGF, that is epithelial growth factors, VEGF, that is vascular endothelial growth factors, and transforming growth factors. So basically, each and every factor has its own useful use that we can see. That is, VEGF is for growth and new generation of vascular endothelial cells. Transforming growth factor is growth and neogenesis of epithelial cells, vascular endothelial cells, and also it promotes good promotion of wound healing. So that's this is the process of PRP therapy which we usually do. So I would just share a small how we do the processing or how we do it. So basically, we need little more blood from the patient if we need to inject the PRP intrauterine. So intrauterine means that is in the subendometrial layer. So we usually have to take around 10 ml, because the plasma, the platelet rich plasma which we use, that has to be necessary. And when we have to first prime the catheter or the needle which we put in through the operative sheath. So that is why the lot of fluid goes in the priming. So that is the reason we need to take adequate ml of blood and prepare the platelet rich plasma from it. So this is just the process, and I think I'll just show you how then it is centrifuged, and After the centrifuge, the plasma is separated and it is uh, used, and it is attached to the insert the needle into the upper surface, withdraw around 6 ml to 8 ml or more of PRP depending upon how much you want to use. So basically for the endometrium, we usually use around 0.5 to 1 ml, and we usually inject it in the lateral walls and the upper walls. So that is how the plasma, platelet-rich plasma and the concentrated plasma is made. So this was again a study which was used, that is 5 women who had cancelled cycles due to refractory thin endometrium. In a new cycle, of course, estradiol was given 12 milligram per day, and on the 10th day, PRP was done and obtained, and 2 centrifugations of 15 ml peripheral blood was taken. 1 ml of PRP immediately was given into the cavity with the catheter. So that was about the PRP, and it definitely improves the pregnancy outcomes during in vitro fertilization. So we usually do this at least a month prior to doing the embryo transfer. So this definitely helps in when the patient has some partial Asherman's or maybe some salpingitis, or she has had any recurrent or repeated IVF failures, in cases of other problems like thin endometrium. So maybe this was a big review study which I came across, which says revitalizing female fertility with platelet-rich plasma. Is it a hype or a hope? So this is a huge review literature which I came across, and definitely they say that yes, it has gained popularity as an experimental tool in regenerative medicine, but with potential applications in reproductive medicine. But yes, of course, there has to be lots of things which are still have to be nicely, we have to have some standards like SOPs. So that is how we can come to a conclusion, and it needs little more studies to be done for this PRP. So management, this was again a study, a pilot study, which was showing a management of thin endometrium by hysteroscopic installation of platelet rich plasma into the endomyometrial junction. And of course, they also had such beautiful results with PRP, showing good results with the thin endometrium. So this was a study which was showing which was done for intrauterine platelet-rich plasma versus injection of GCSF for the treatment of thin endometrium in infertility. So this study was proved that injection of GCSF was more effective for treatment of thin endometrium compared to intrauterine PRP infusion. So, though the clinical and the chemical pregnancy rates were comparable, a high percentage of women were clinically pregnant in the group which had GCSF injections. Intrauterine PRP could also be a good alternative for thin endometrium. We do not deny that PRP is not effective, but yes, this study, which we had done few years ago, showed that. So, of course, we need more studies and RCTs for comparing and proving the effectiveness of these medications for the treatment of thin endometrium. So, this was again a huge single center experience from Romania, which showed PRP efficacy on endometrial thickness and infertility. So, this concluded that PRP definitely has a positive effect on promoting the endometrial proliferation, improving embryo implantation rates, clinical pregnancy rates for women with thin endometrium. The observed improvements in thickness following PRP treatment indicated its ability to positively influence endometrial receptivity, ultimately which led to improved IVF outcomes. So that is our whole and soul motive. So either you give PRP or you give stem cells or you give GCSF, it you should give a pregnancy to the patient. That is our last motive. So the continued research and controlled clinical trials are necessary to further explore the full potential of PRP in reproductive medicine and establish standardized protocols for its application in IVF treatment. So, of course, this was one more thing which was also used, that is GnRH agonists, which is tryptorelin. So, luteal phase support with GnRH agonist has also been employed in some patients with thin endometrium who undergo IVF. So, Kubler et al. Had a prospective study of 120 patients who underwent IVF with thin endometrium to either GnRH agonists or placebo during the luteal phase. So, during the luteal phase support, it was given. So, these 60 patients, they received 0.1 milligram of triptorelin on the day of egg retrieval, embryo transfer, and 3 days after embryo transfer, while the remaining 60 patients, they served as a control. So, endometrial thickness increased from 6 to 8.92 in the study group, which was quite significantly higher than the increase which was noted in the control group, which was not much, 6.8 to 7.1. So the pregnancy rate was also significantly higher in the study group versus the control group. So it was P was significant. So coming to scratching and local endometrial injury, so this is something which we usually do, that is local endometrial scratching. So the tissue injury procedures like biopsy or hysteroscopy in the cycle prior to IVF, they induce the stem cell differentiation, increase the endometrial receptivity during the IVF treatment cycle. Most experts during IVF and IUI, they have started doing it. So this was again the studies which showed the implantation rate was 10% more in the biopsy group compared to just 3.3 in the control group. And the clinical pregnancy rate was also much higher, that is 27%. There was significant difference in embryo implantation rate, clinical pregnancy rate, ongoing pregnancy rates between these two groups. So it was quite comparable. And another study also showed clinical pregnancy rates which were higher in biopsy group as compared to control group, that is 25. So this is about endometrial scratching. So I would just show you this video here. So we are just seeing the two ostia and doing the endometrial scratching. So we usually do this endometrial scratching and adhesiolysis. So if you do not see the cavity, you have to just go slowly with a good distension. You can definitely go and see the cavity. This is again a case with thin endometrium which needs adhesiolysis. And then this is the final picture. Sometimes you may come across some things like some polyps or septums. Of course, that is altogether a different story altogether. So basically, you have to see the problem in the hysteroscopy, and rejuvenation could be some anatomical defect which you may have to remove or you may have to cut down, and that could be some Mullerian anomaly, it could be some septum, it could be some polyp. So that is the reason you need to correct it, which is also a part of rejuvenation. So we usually go for a pre-IVF hysteroscopy. We usually do LEI, that is local endometrial scratching. And this is again a small video showing an Asherman's. So this is, you can see that the endometrium is very pale and very thin. So we are just trying to enter the cavity, and this is, you cannot see the cavity at all. So you can just see a small kind of a tunnel which is just going inside, and you have to still wait. You have to have a lot of patience when you have Asherman's, because Asherman's is something which really takes a toll, which really tests your patience. So you can see all adhesions. You can just see all, net type of things and no cavity at all. So you have to just slowly dissect through the center and see to it and try to see the two osteas. So your endpoint will be where you can see the two osteas from a panoramic view, and that is how you can feel that yes, you have done a beautiful rejuvenation for the patient. Not be scared, but start from the center, and slowly you have to you open your scissors, bury the scissors slowly and cut, so that you do not try to injure, but you have to see to it that you nicely do the dissection and you can see the two osteas. This is again a PRP installation. The subendometrial PRP installation is done with a special PRP needle. If you do not have a PRP needle, you can simply use a nice Cook's catheter, which Cook's pickup needle, which we usually use, and we have to usually put it subendometrially. See to it that you do not go very much deep into the myometrium, and then we usually use a Foley's catheter and keep the Foley's catheter for at least 5 to 6 days. Or if the Foley's comes out automatically, that is also fine. Don't We do not have to worry, but just counsel the patient so that the patient is not worried. So coming to the last thing, that is stem cells. Of course, I'm sure many of the stalwarts are going to speak on this, but this is also a part of rejuvenation. The ideal candidates are, of course, for thin endometrium, patients with persistent thin endometrium with repeated implantation failures, treated cases of tuberculosis with thin endometrium, Asherman's grade 3 are the patients who need it. Recent case reports of endometrial reconstruction using autologous bone marrow stem cells followed by conception by IVF in 2 patients. They've gained considerable attention and they seem to be breakthrough for conception in IVF cycle. So these, of course, there are lots of studies and which have been done on stem cells in spheroids improve the fertility in model with damaged endometrium. So of course, stem cells is lots has been studied, lots has been told, lots has been shared. So of course, stem cell therapy is also one therapy which is useful for thin endometrium. But my favorite is still PRP, that is platelet rich plasma. So we usually use either PRP or we use GCSF in our patients. And touchwood, we have had good results and pregnancies with our patients. Yes, maybe stem cells, of course, we will definitely use it in our patients, which definitely do not get results with GCSF or PRP. So, just to conclude, yes, rejuvenation is a must, and we usually try to see the cause first, the cause of her infertility, then her cause of her thin endometrium, which is causing her the infertility. And yes, rejuvenation is the key to it, and it will definitely help the patient. So, it is tailor made. Not all patients need rejuvenation, but yes, those who need it will definitely benefit with rejuvenation. So I urge everybody of you all to do a pre-IVF hysteroscopy for your patients. If at all if it has not been done, or even if it has been done long back, so it is useful for you to see the uterine cavity before you do her embryo transfer, so that you give her a pregnancy, which is very important. At the end of the day, the patient doesn't know what you're doing for her. You're doing PRP, you're doing GCSF, you're doing stem cells. She's only worried that bus ek bacha de do. So that is what is important. So yes, of course, rejuvenation is the way to go, and it will definitely help the patient. Uh, Thank you so much for your patient hearing. So this is our academy. We also have other doctors, that is Dr. Chandani coming to us for fellowship in cosmetic gynecology, and we also have our workshops and ART hands-on workshop. So I just invite you all to come to our humble place at Killapadi, and I'm sure we'll be there to give you a good hospitality. Thank you everyone for your patient hearing.
Thank you, Dr. Aditi. That was a fantastic presentation. Dr. Shruti, can you take the questions?
Uh, so, ma'am, the first question is, intraendometrial PRP injection can it be repeated?
Intraendometrial?
PRP injections, can they be repeated?
Actually, we do it only once, and we do the endometrial study for the patient. If the endometrium is not coming up that well, so you can repeat it another one more time, but not too many installations will help actually, because if the endometrium has become too refractory and it's not responding, then she may need some other modality of treatment.
Okay. For endometrial scratching on OPD basis, what do you use, ma'am?
We do not do scratching on OPD basis. So we usually see to it that we do it hysteroscopic guided. We do not do it blindly. If at all the patient is not willing, or if she has to go back, so then we usually do intrauterine GCSF installation. But scratching, or we do usually do it under hysteroscopic guidance and under general anesthesia.
Okay, ma'am. Okay. The next question is, on which day in an FET cycle GCSF should be instilled?
So GCSF, basically we instill it on day 9 or day 10 of the FET cycle. Then we assess the endometrium. If the endometrium is good and up to the mark, then we go forward for this frozen embryo transfer on day 13, on day 16 of her menstrual cycle. So we usually do it on day 16 or day 17 of the frozen embryo transfer, her frozen embryo transfer.
Okay. Okay, ma'am. Any role of PRP in oligomenorrhea?
PRP in oligomenorrhea, it depends upon the endometrium actually. So if her endometrium is thin, and because of that, definitely she has oligomenorrhea. So you can definitely give her a PRP and check for her endometrial thickness. But per se, just oligomenorrhea, it depends upon the patient. If she's doing it for a fertility purpose, then yes, definitely PRP can be given to her. We have to also check her hormones. It could be some other cause, and it could be because of premature ovarian failure, or it could be because of some, some COX, or some any other cause which is leading her to oligomenorrhea. So it's important to see her hormones also. We have to check her thyroid, prolactin. We have to also check her D2, FSH, LH, E2, FSH especially, her AMH, because these are the other hormones which will definitely guide us and tell us why she is getting oligomenorrhea.
Uh, PRP in chronic endometritis, can you elaborate on it?
So basically, when we have diagnosed her with endometritis, we have to first treat her with a good course of antibiotic treatment. Antibiotics may also help to not worsen her endometritis, and basically it is all because of the adhesions, or because of some chlamydial infections or gonorrheal infections, etc. So these could, the antibiotics itself will help her to not, to abet her endometritis further. And then definitely we can give her this PRP installation once her endometrium looks okay and not very angry looking. So that is when you can definitely give her a PRP treatment, but not during when you feel that it is because of some chronic infection.
Okay. Okay, ma'am. Anybody else wants to ask any questions? Please go ahead. Dr. Vasundhara is asking whether GCSF has to just be instilled and not injected into the cavity.
Yeah, so GCSF we usually just put it inside, like just how we do an IUI procedure. So we usually just instill it inside, and we usually tell the patient, ask the patient to lie down for some 10-15 minutes, and that is when we just we do it usually under ultrasonographic guidance. So that is also, we do not do it blindly, so that we are very sure that it is definitely inside the endometrium, and that is how we do a GCSF installation.
Okay. Okay, ma'am. Anyone else wants to ask any questions? You can unmute and ask, madam. Okay. What is the difference between PRP installation versus hysteroscopic injection of PRP?
Just like my previous speaker, Dr. Lavanya said, it's better that we do it hysteroscopically, and we just put it subendometrial infusion. That is important, so that it gets nicely absorbed, because if we just instill PRP, it may or may not be, nicely absorbed like it would get absorbed when you are injecting it subendometrally, that is infusing it subendometrally. That will definitely give a better, a better lookout or a better option than just putting it inside, because many of it may just, flow out when the patient gets up. So it's better that we just instill it nicely, and that will definitely give us better results than just infusing it and just pushing PRP, which may or may not have that better results with just pushing it inside. So I think hysteroscopic PRP installation is definitely a better option comparatively.
Okay. Someone has asked, ma'am, that what amount of GCSF has to be instilled? Any antibiotic coverage post procedure is needed?
For GCSF and antibiotic coverage,
What is the amount of GCSF?
so GCSF, basically we have the pre-filled syringe. So we usually use around 300 micrograms of GCSF, which we put it intrauterine. So that is just
Yeah.
put inside, so that gets absorbed. So around 300 micrograms. But the only thing is, sometimes WBC counts may just increase because of GCSF per se. So that is where the we should all know that yes, the GCSF has been instilled, and that could be the reason for our WBC count to just increase a little substantially. But per se, there is no role of antibiotics per se, unless the patient has any history of fever or any history of infection. Otherwise, per se, no role of antibiotics.
Okay. Uh, PRP subendometrial has to be instilled in both the walls or any wall to be injected. I think they.
Yes, so in the both the walls, in the lateral walls, we usually inject it. Uh, so around zero point 0.5, 0.5 ml of PRP can be injected, because it's a small uterus or a small cavity. So too much of it may or may not be beneficial. So around zero point 0.5 to 1 ml can be injected.
Okay. What are the contraindications for a PRP procedure?
Contraindications could be if the patient has, if the patient is having some after the procedure, if she has had any problems, or if she's got some anaphylactic reaction. So that could be the only contraindication. Per se, there is no contraindication. But if the patient has had any history prior uh, of any anaphylactic reaction, then you may have to be little careful when you are injecting, and you have to definitely be on the lookout for any other reactions which she might get.
Okay, I think so. That's all. All the questions are done. Thank you, ma'am. Thank you for
Thank you, Dr. Shruti. Thank you, Kiran sir.
Thank you. Thank you. Any other questions, anyone? It's
one
already,
more. Yeah, one more has come in.
yeah.
Any pre-procedure steroid cover needed to overcome anaphylaxis?
No, there is no not necessary. It's not necessary to give any steroid coverage per se for that.
Okay.
So it is autologous, no? So there is no question of anaphylactic reaction.
Yes.
Yeah. Any other questions? Okay. So we are done with the session. Thank you, Dr. Aditi, for being with
Thank
us.
you, sir.
Thank you. So just remember next year I'm also
Yes, sir.
13, 14, 15th of March, Geo Center, Mumbai.
Definitely, sir.
So we'll end the session and we will rejoin tomorrow at 8 o'clock sharp.
Yes,
Any
sir.
other questions? Any other queries? Anything you cannot do? Anything you want is lacking? So today there was one talk which was not covered. So we will cover it in the due course.
Thank you, sir. Thank you,
Thank you,
ma'am.
sir.
Chalo.
Thank you.
Okay. Bye bye. Cheers. Good
Bye,
night.
sir. Bye, sir.
Thank
Thank you.
you. Thank you, Aditi. Bye. Bye.
Bye, sir.
I'm ending the meeting for all. Thank you.
Yeah.